on the base of that information, I want us to see if there could be another way of doing something in uveitis. I think when we come to the end of the presentation, we will see the meaning or the significance of that statement. What if there could be another way? So you can go to the second slide. The second slide, kindly. Yeah, so we want to review the last presentation that I had. Then we'll see other complications that are related to uveitis. Then we'll see the treatment options. Then we'll have questions and we'll have comments. So as I begin with the review, we saw last time that we should not see the eye as an independent organ in the body, but we should see the deep connection that lies between the eyes and the entire body. And we saw that the eye is very significant in trying to assess what's actually happening in the body. We saw that between the body, or the entire body and the eye, there is a connection of the blood supply system, the nervous system, and in some conditions, like an example of arthritis, if there is the rheumatoid factor or the rheumatoid antibodies in the bloodstream, which will initiate inflammation in the body, this will be presented both in the joints of the body and equally will see uveitis in the eye. We equally saw some conditions like sarcoidosis, tuberculosis, and most of them, so that all these conditions, apart from presenting themselves in the body, they equally show themselves in the eye. And so we came to actually say that the eye is not only a refractive structure, having the cornea, the lens, and the clear gels, that is the aqueous and the vitreous humor, but equally that clear structure can be used to assess what's actually happening in the body. And so we use an analogy of a house and a window. And so the eyes can be used as a window to see what's actually happening inside the body. And so as we work as optometrists, we should equally make ourselves clinically relevant by using the information in the eye to try to understand what's actually happening in the body. And this can help us to give information that is significant to the patient and equally very, very relevant to the other physicians. Because sometimes when we are always in our clinical practice, maybe in our attachment, and maybe where we'll work in future, a patient will come into the clinic and you'll be asked, and he'll be sent into your place of work for some consultations and equally for some tests. And I think if you have a deep understanding of this connection, you'll become very significant to the doctor who will send the patient to you. And so we began by seeing uveitis, and I think in future we'll equally see some conditions which have a very deep connection in the eye, and they can be used to assess what's actually happening in the body. We can go to the next slide. Slide number 3. Slide number 3. Thank you so much. I think now you can hear me. You can hear me quite well. I think now I can be heard quite well. So today we want to see a connection between uveitis and glaucoma. And so I want us to see the structure of the anterior chamber of the eye. So we can see we have a structure called trabecular meshwork. The place where the aqueous humor is always drained or carried out of the eye. And so in uveitis, we understand that it's an inflammation that happens in the uvea, and we are seeing anterior uveitis. So we have the iris and the ciliary body. And so I want us to take the case where those inflammatory cells will come and clog the trabecular meshwork. And so as a result, when they are clogged, the aqueous humor will not be drained out of the eye. And so as a consequence of that, then they will be trapped in the eye, and this will increase the intraocular pressure. And so uveitis in one point, it can cause what we call open angle glaucoma. You can take that through a picture. Go to the next slide, kindly. Yeah, so you have that open angle glaucoma. Yeah, so the trabecular measure or the venous angle or the vein structures are blocked by the process of inflammation. And so as a result, aqueous is not drained out of the eye. And so you have an increase in IOP that will cause open angle glaucoma. Equally, when you have the inflammation process, the cells, especially fibrin, may come and settle between the iris and the lens. And so as a result, aqueous will not be coming from from the posterior anterior chamber into the anterior part of the anterior chamber. And so as a result, you can have what we call closed angle glaucoma. And if you have closed angle glaucoma in that condition, what may happen is this. The aqueous will settle behind the iris, behind the iris itself. And so as a result, it will accumulate and begin to push the iris forward. And so as it's pushing the iris forward, the peripheral part of the iris may come into contact with the cornea. And so you can have what we call an iris bombing. And so this will cause an attachment between the peripheral cornea and equally the peripheral iris. And as a result, you'll have that type of glaucoma. And so you see, this is a double tragedy because it's causing inflammation between the lens and the iris, and equally between the iris and the cornea. I can go to the next slide so that I can equally explain another thing. And then equally, when you have uveitis, we know that we have cells of inflammation coming into the anterior chamber, and they always get attached to the endothelial layer of the cornea. This may equally affect the structure of the cornea because it may begin to damage the endothelial cells. And as a result, someone can have a band-shaped keratopathy where the cornea will have opacity that looks like, as a result of those inflammatory cells affecting the endothelial cells of the cornea and equally affecting we call it the pumping mechanism of the corneal endothelial cells. Can we go to the next slide? Yeah, then equally, when you have uveitis, we know that uveitis attacks the ciliary body. The ciliary body has what we call ciliary processes, which will always produce aqueous humor. And so if they're affected after some time, if it affects the ciliary body persistently, this will begin to affect the production of the aqueous humor. And if this continues for a good time, aqueous humor will not be produced. And as a result, the eyes will begin to shrink because there is no fluid to give the eyes globular shape. And if this happens for a very long time without being addressed or being checked, then the eyes will completely shrink, and the patient will have what we call a phthisis bulbi, or a shrunken eyeball, as a result of uveitis. And so, as you see, uveitis is not just let me say a mild disease or a disease that someone can trifle with, but it's a very big disease of the eye, which should be addressed immediately. You see the condition, you should try to see what may be causing the condition, and then you should address it as fast as possible to avoid such consequences that may cause these dangerous effects to the eye itself. And so as we proceed, I want us to look at the treatment options of uveitis. So we can go to the next slide so that we begin with this first treatment option. So number one is cycloplegic. So I want us to see why we use cycloplegics in treating that. So you have example like atropine sulfate, that's 0.10%. Then if the person is allergic to atropine, you can use somatropine or you can equally use cyclopentolate. So we understand that when someone has uveitis, we have inflammation, and when someone comes into a place where you have light, the eyes or the iris sphincter muscles will have to constrict in order to reduce the aperture of the pupil. But because of the inflammation, this will be very painful process, and sometimes it will always produce what we call prostaglandins. So this person will have photophobia because when it comes into a place where there is light, the sphincter muscle of the iris will have to constrict, then will have to produce prostaglandins, and they can equally come into contact with the lens, and so this is a very painful process. And so because of that painful process, we'll have to give cycloplegics in order to let me say in order to prevent the sphincter muscles from constricting and reducing the pain. And then equal cycloplegics will help to break the neck or the connection between the pupil and the lens, because if they come into contact, you know that this may cause what we call a cataract, and it may cause glaucoma. And so, because you want to break those connections and give cycloplegics, the iris muscles will begin to dilate, and they'll break the connection between the iris and the lens, and this will help so much. So you can never give atropine sulfate. It's always given, I think, 3 times in a day for a considerable amount of time. Then, if the patient is allergic to atropine because of the contents, maybe you can give omatropine, or you can equally give cyclopenicillin. And go to the next slide. Yeah, then because uveitis is an inflammatory process, we have inflammatory cells coming into the eye. And you know that the body itself will always produce what we call natural steroids to address the condition. But because they are not very effective to address the condition, so we have to integrate something external, that's external steroids, to come and handle the condition. And so you'll either give prednisolone, dexamethasone, or equally betamethasone. But from our previous experiences, but we can equally think over this, and we'll give our comments as we come to the end of the presentation. We always prefer to use prednisolone, largely because prednisolone has a
routine with friends and the fans. So do not go anywhere, because tonight we're not just watching history, we get to be a part of it.
So it always have what we call
this is what it looks like from above at the stock, Charlotte. This is
okay. Prednisolone always have a deep penetrating power, and so it can go into the uveum and check the inflammation process. So as you give prednisolone, there is something that you need to do. What we call you always do what we call okay, you reduce the dosage with time, what we call tapering of the dosage. I think the reason is this, but we can equally share the reason we come to the end of the presentation, because we are here to learn from one another and equal to give different ideas. So the reason is this: the body always produces natural steroids, and the body steroids are not only meant to check inflammation, but they equally help in other body processes. So as you give up an external steroid in the body will now begin to reduce the production of its natural steroid one by one. And so as this is reduced with time, if you will remove the steroid, but if you remove the steroid at once, then the body will still have a very low threshold of that steroid production, and this may affect the physiological process of the body, which are controlled by steroids. But if you reduce the prednisolone step by step or by tapering, it will give the body time to respond back and to begin producing steroids as it is produced steroids before you gave the external steroid. So it's always advised that as you give steroid like prednisolone, you should always taper these steroids. You should always remove them by tapering, or you remove them progressively by reducing them progressively. But you should not just remove them at once, because it may affect the body's natural process of steroid production. We can go to the next slide. The other thing is you give a we call them a non-steroidal anti-inflammatory drugs like ketorolac and like Enac. The reason is this: so we know that these drugs will always reduce the pathological processes, which will always cause pains in the eyes, especially in handling what we call prostaglandins. And so as you give this drugs into the eyes, as you give them topically into the eyes, they will help so much in reducing the painful processes, the painful feeling in the eye. And so if the patient has a lot of pain, you can equally add this in order to address the painful sensation of the eye. We can go to the next slide. Yes, then equally, if the patient may be having a pupillary block, glaucoma, or equally if the patient has open angle glaucoma, you want to, okay, it's always pupillary block glaucoma. You want to restore the connection or the communication between the posterior and the anterior chamber. Assume if the entire lens is covered by the iris or is connected to the iris. So you want to restore the connection. And so you'll also send the patient for a surgical procedure. If you cannot break the synechia or the connection between the iris and the lens by using cycloplegics, you have to send the patient for surgical intervention in order for you to prevent the patient's eyes from being destroyed due to glaucoma. And so it's where they'll put, let me say, they'll induce a hole in the iris, and this will help to connect, or it will help the achiasima to come from the posterior chamber into the anterior chamber. This will break what we call the synechia, and then it will equally open the angle, and the achiasima will still be drained, or it will still be carried out of the eye. You can go to the next slide. Yes, then equally, we can equally do some supportive measures like hot compress and equally sunglasses. So hot compresses will help in doing this. When there is inflammation in the eyes, there'll be, let me say, there'll be stasis of blood in the vein. So blood will flow very slowly. When you do hot compresses, which is just simply, you take a clean cloth, especially a cotton one, then you place it in warm water, not hot water, but warm water. Then tell the patient to close the eyes. As you give the drugs, after giving the drugs, maybe after he has relaxed, you cannot put it on top of the eye, or on top of the skin on the eye surface. So this will help to promote the flow of blood in the veins. And so as let me say, as the old blood is replaced by fresh blood, it will equally help to the inflammation process, and it will equally help to increase the rate of healing in the eyes. Then equally sunglasses can help reduce the amount of light getting into the eyes, and this will reduce the need of the iris sphincter muscle from constricting and causing the pain. You can go to the next slide. Okay, can go to, okay. Let me some ideas here. Then we'll give our comments. So equally, sometimes maybe giving a patient some medications, but unfortunately the patient is not responding. So as we saw last time, maybe the cause may not be restricted to the eyes alone. Maybe the patient may be having an infection from the body, or equally an inflammation from the body. And so if the patient is not responding, you've given this medication, he has come for review, he's not responding to the medication, it's now good for you to try to assess if there may be other symptoms. And I think this process of assessing should begin right from the first day. But so that you see if the patient may be having something presenting in the body apart from what you are seeing in the eye. So this will help you to address the body, the eye condition, but equally talk to the patient's physician in order for you to address the entire thing. Because maybe assume you are giving steroids in the eyes and equal cycloplegics, but the cause of the uveitis is an infection. And if you give steroids for infection in the eye, so you'll still have those tuberculosis bacilli in the eyes, causing the uveitis, damaging the ciliary body and the entire uvea. But because you may have neglected to do an general exam, you may not check actually what's causing the condition to grow, let me say, to exacerbate. That's very good for you to try to see what may be the cause of the condition from the very start. Then equally, another severe consequence of uveitis if it is not treated earlier. Things like when this uveitis begin up to spread, this anterior uveitis, the ciliary, into the pars plana, going to the choroid, then going to the retina, then locally going to the macula. This will cause what we call cystoid macular edema. Then going to the vitreous. So the entire eye has an inflammation. So it's very good for you to address the condition as fast as you recognize it. Then you should equally remember that uveitis may equally have connection with some other conditions of the body. So try to see this uveitis from a general perspective instead of you seeing this uveitis from just a restricted perspective. Then that thing, I was trying just to think as a medic. People who discovered or the people who proposed we can use steroids to treat inflammation conditions, so that this condition is caused by what we call inflammatory cells in the body. The body can equally produce steroids, and so they suggested that you can use steroids to treat the condition. People notice that in some uveitis, if they don't respond very fast, we equally give them what we call immunosuppressants, things like cyclophosphamide, that for you to address the condition. And so I was equally thinking that apart from that, in medicine, we always have four methods of treating a condition. We have what we call chemotherapy, so we use that to treat a condition. We have what we call hydrotherapy, things like cryotherapy, and equal warm compresses. We equally have what we call radiotherapy, things like X-ray and such stuff. Then equally have what we call dietotherapy. So the body itself is made from a diet. We understand from a biology, if someone takes food, this food will be broken down into the gastrointestinal tract, then goes into the bloodstream. Then this bloodstream will transport the food into every part of the body. And we have some food components which are naturally, let me call them anti-inflammatory. And so myself, sometimes I tend to suggest if someone has a condition like arthritis, we can integrate or we can equally add these inflammatory foods into the into that. And equally, someone has uveitis. Apart from you giving him steroids, giving him NSAIDs, cycloplegics, and other medication, I equally think that because the eyes is part of the body, if you give foods which contain anti-inflammatories, they'll be supplied into the body. And even though maybe the consequence may not be that significant, but because they are anti-inflammatory, they can help in addressing the condition. So I think we should think along this line, because I think education was not only meant to make students receive this information and repeat it, but you can equally try to think diverse in a diverse manner and try to see if at all it's possible for us to use this diet to address conditions our patients are suffering from. So I tend to think that we have a lot of ways that you can use to address uveitis, apart from the drugs that we always give, and apart from the surgical procedures. And so as we study, you see the inflammation process, you see those chemical elements of inflammation, and equally the entire process of inflammation. We can equally try to see which drug can be given address the inflammation process. So the person suggested things like immunosuppressant, equally so that when I give this immunosuppressant, it can help to address the condition because he understood the pathophysiology of the inflammatory process. I tend to think that it's equally possible for us to use other ways for us to address the uveitis process. I think with them, I have finished my presentation for today. I'll just give time for questions and comments, and I've shared some strange ideas, and I'm open for criticism. We can equally share our ideas to see if we can integrate what I've shared and what you have in your mind. Otherwise, thank you so much. So back to you, Faith.
Okay, thank you for the presentation, Daniel. I think we can take questions, but before we have questions, we have Dr. Chika around, so he can give us a comment and maybe something to add on the presentation.
Thank
Dr.
you very
Chika,
much.
please.
Thank you. I hope you can. Am I audible?
Yeah, I can hear you.
Yeah, fine. So, thank you for the opportunity.
Okay, it seems like Dr. Chika just had a connection problem. So let's just take questions and then we'll listen. We'll hear him after he comes back.
Sorry, I don't know if you're hearing me. I was cut off by the internet. Hello?
Hello, we can hear.
Yes. So what I was trying to say, thanks Faith and thanks presenter. That was an elaborate talk on uveitis. Just one thing to add. Most times when people are treating uveitis, they always forget the systemic relationship. So you that there is a indication and systemic issue. It could, as far as infection and major infection. So, whenever a patient actually a comprehensive history of the patient, look at the begin diagnosis, examination.
Dr. Chika, your network is wavering. Sorry, your network is wavering.
Hello?
Yeah, hello.
Can you hear me?
We can hear you, but it's not clear. Utashaenda. Okay, anybody with a question, you can just write it on the chat box if you're afraid to speak it out. Otherwise, we're going to close the session. And I want to recognize the presence of everybody who has joined and is not a member of MOSA. Thank you for joining. I can see Given. I'm not sure if there is somebody else. I want to recognize all of you for choosing to join today's CME. I hope you have learned something, and let's wait for the next CME. Yeah, basically, thank you and have a good evening.
Have a good evening too, Faith. Have a night.
Good night, Onyancha.
Hey, boy. Bye.
Hello, Dr. Chika. We just closed the session. I'll text you and then you'll give me the insights and then I'll share them with my fellows.
Okay, that would be okay. That would be okay.
Okay,
I'm having very bad network challenge here. Yes. Thank you.
Okay, thank you for joining. Have a good evening.
You too. You too.